Share the screen, guys. Yes, I hope it is visible to all of you. Yes. Okay, so can someone tell me what is tachyarrhythmia, guys? What is tachyarrhythmia or tachycardia? Can someone tell me what is tachyarrhythmia? Yes, people, tell me. Everyone, tell me what is tachyarrhythmia or tachycardia? What do you know about tachycardia? Yes, anything you know about tachycardia, tell me. Yes, people. Okay, very nice. Increased heart rate, perfect. More than 100. Okay. Increased heart rate more than 100 per minute. Okay. Okay. More than 110. Somebody is telling more than 110. Very fast heartbeat. More than 90. Somebody is telling 90. Somebody is telling 100. Somebody is telling 110. Okay. So you mean that faster pace is the reason, or faster pace of the heart is tachycardia, you mean, right? Okay. Yes, tachycardia means high heart rate. Okay. High heart rate. What else do you know about tachycardia? Tell me. What else do you know about tachycardia? Yes, guys. What else do you know about tachycardia? Yes, people, tell me. Yes, 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 yes. Tell me, guys. Fast. What else do you know about tachycardia? Yes. Yes, people. What is tachycardia? I mean, do you know anything else like types, symptoms, or anything about tachycardia or ECG things? How? Like anything else do you know? Palpitations. Okay. Yes. Yes, guys. High heart rate, narrow ECG. Okay, narrow ECG means narrow what narrow exactly? Distance between RR. Okay. Yes, and distance between R. Okay, so let's discuss. Okay. Tachyarrhythmia. So today we are going to talk the same thing. Tachyarrhythmias, types of tachycardia, sign and symptoms, diagnosis, treatment, prevention, special cases. But those special cases may not be there today because see, tachycardia is a big chapter. And we cannot finish tachycardia in a day. You understand that? We cannot finish tachycardia in a day. We need more time to discuss tachycardia. We need more days to discuss tachycardia, more classes. So we will take at least 3 to 4 classes to understand the different tachycardias, right? Today we will just understand the basics of tachycardia. Today we will just understand the basics of tachycardia. Okay, so let's start. I'm keeping my video off right now for some time. Okay. So we will talk about tachycardia. So, right, guys, can someone, just tell me or just calculate the, heart rate for these ECGs? Yes. Can someone calculate the heart rate for these ECGs for me? Yes, everyone. Yes, guys, do it. Yes. Heart rate for the first ECG, like the above one. Calculate. Yes, people, fast, fast. Tell me. Yes, guys. 125 above. Okay, 125 above one. Okay. First, everyone tell me the heart rate for above 1. The first one. Yes, tell me, guys. 125. Okay. Okay. Yes. 125, 125, 125, 125. And the heart rate for lower one, can someone calculate? Heart rate for lower one, 375. My God. 300. Okay. Yes. 300. Fine. 300 or 300, more than 300? What do you say, guys? It is 300 or more than 300? Yes, people, tell me. 300. Okay. Fantastic. 300. Fine. Then, yes, 300. Fine. Anyone else who wants to calculate? Who is calculating? Yes, guys. Anyone is calculating? Yes. Yes, guys. Anyone calculating heart rates? 300. 300, 300, 300. Only four small boxes, sir. Four small boxes. Okay, let's count first. See, if you count here, almost two and half large boxes. In the first one, two and half large boxes, two and half large boxes, right? It is like, and small boxes, if you count, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 12, 13, almost 13. So the heart rate will be around 125 or 120. Okay. And in the lower one, it is exact one large box, if you can see. Exact one large box. See, one, two, three, four, five. Five small boxes means one large box. Anywhere if you see, that is one large box or five small boxes involved between R and R. You know, five small boxes means one large box. That means it is 300. That means it is 300. Let's see. So heart rate more than 100 or 100 beats per minute is called tachycardia, and ECG strips showing tachycardias, right? So first one is actually tachycardia, normal, sinus tachycardia, and below one is supraventricular tachycardia. Okay, first one is around 140 beats per minute, so and below one is around 300 beats per minute. 300 beats per minute. See, in that, like, there are a little bit differences in R and R, but it is around 125, 130, 140, right? Right. And lower one is 300 beats per minute. Okay, 300 beats per minute. So let's understand what is the, like, how common that tachyarrhythmia can be, like, and how dangerous it could be. So the prevalence of ventricular tachycardia is approximately 54,000 per 1 lakh in men and 55,000 in, 55,000 per 1 lakh in women with hypertension, valvular heart disease, or cardiomyopathy. Normally, if the people have cardiac disease, understand, if the people have existing cardiac disease, then these things are dangerous, right? These things are dangerous, and these things are having more prevalence. More prevalence means, like, see, in the normal people, if it is, in normal people, it is 31,000 in 1 lakh in men and 30,000 in 1 lakh in women with no cardiovascular disease. Understand? So that is in men and women, like, normally 30,000. And if you see one more thing, in men and women, these two things are, like, if the man has no cardiac problem, it is higher in men. If women, I mean, no cardiac problems, it is lesser in women. Like, 3%, 3.1%, right? 3%, 3.1%. But if you look at, look at the people who do not, I mean, who have the cardiac problem, it increases suddenly in men and it decreases in, sorry, it increases in women and it decreases in men, right? In men, it is 5.4%. In women with cardiac disease, it is 5.5%. So cardiac disease are not so common in women, but if they have cardiac disease, they can get more, arrhythmias or more cardiac diseases. Understand? So it is very dangerous, and the death rate of tachycardia is quite high in supraventricular tachycardias, or atrial fibrillations, ventricular fibrillations, and multiple other tachycardias are there, right? So the prevalence is very, very if we say like you know alarming type of thing. It is very alarming, like 3% and 4%, right? At 3 and 5%, right? That can usually be there. Okay, and what is mechanism of action, right? So mechanism of action is mix of multiple things. Mix of multiple things means like if you start from normal primary increased sympathetic activity, primary increased sympathetic activity, that can happen because of anything. That can happen because of anything like stress, that can happen because of sedentary lifestyle, that can happen because of smoking. So I mean, that can happen because of drugs or hormones, anything. Primary increased, or maybe hypertension, primary increased sympathetic nervous system, or sympathetic activities, right? That can lead to increased SNS traffic. Okay, or that can increase the noradrenaline in plasma, right? SNS traffic or plasma noradrenaline, it can increase the noradrenaline in plasma. Okay, then this is one mechanism of action. Another mechanism of action is partial autonomic neuropathy. Like if there are the neuropathies means weakness of the neural nerves, right? Or weakness of the neural network. Okay, I mean nerves, mostly nerves, or the neurons, or the neurotransmitters, whatever are the parts of nervous system. Partial neuropathy means the weakness of our nervous system, that can lead to inadequate vasoconstrictions. Definitely, if there are if our muscles and things are weak in the heart, definitely it can lead to inadequate activities, inadequate functionalities. Inadequate functionality means vasoconstrictions or venoconstrictions, like either vessels, or I mean all the vasoconstriction and or venous constrictions can happen in that, and that can cause blood pooling. Blood pooling means in the system, in the central system, blood pooling will be there. The increase amount of blood pooling means the increased amount of blood, the volume of the blood in the body, means like it is not increased, it is not being circulated. Okay, it is not being circulated, so it is increasing in the heart, majorly in the circulation system, means it is increasing in the heart because it is not reaching out properly because of nerves weakness, because of muscular weakness, because of the neural network weakness. So muscles are not like either contracting or not relaxing properly. There is inadequate activities or inadequate functionalities of the your neural system, right? Autonomic nervous system. And because of neuropathy, and neuropathy can happen because of anything, either hormonal differences, or maybe there are some vitamin challenges in the body, like your vitamin D is less, vitamin B12 is less. So due to the dietary functions, that can happen directly to the dietary problems, like either you are not taking the proper diet, or you are not having the proper nutritional food, right? So that could be the direct reason for your neuropathy, right? Or maybe some neural disease, maybe some other problems, maybe some other disease also can cause the neuropathy, like diabetes, severe diabetes or chronic diabetes can lead to that, right? So multiple reasons, but collectively they come to partial autonomic neuropathy, that leads to blood pooling, and blood pooling leads to decreased cardiac venous return, low stroke volume we call it, right? As I told you, the stroke volume of the heart is decreased, and because of this, that the proper amount of blood which should go out doesn't go out. Okay, proper amount of volume, I mean proper volume of the blood does not go out, and it pooled in the heart, right? And then because of that, then what happened is baroreceptors unload, the baroreceptors are unloaded, and again that leads to SNS traffic increment, or the plasma noradrenaline increment. Okay, and then third thing is hypovolemia, maybe because of the dehydration, maybe because of the vomiting, fever, or any kind of problems which can cause hypovolemia, or which can cause dehydration, right? Or because of multiple other reasons, kidney problems, renal insufficiencies can cause to hypovolemia. Or if the person is on diuretics, if the person is on high end diuretics, or high amount of diuretics, that can also lead to such problems, that can also lead to such problems. And that is again a problematic thing for the people you know who are more prone to get this, and majorly they can easily get this. So hypovolemia also lead to decreased cardiac venous return, low stroke volume, and that also lead to directly SNS traffic. Okay. And so what is SNS, guys? Everyone, what is SNS? Anyone? I'm talking SNS for more than 5 minutes. What is SNS? Sympathetic nervous system. Absolutely. Sympathetic nervous system. Right. So, sympathetic nervous system traffic increases, or plasma noradrenaline increases in that case. Okay. Now, the fourth thing what which goes with that is autoantibodies. So autoantibodies directly trigger the peripheral what we say that peripheral pressure or peripheral resistance. We call it peripheral resistance in hypertension, and that can lead to, again, in some cases, that can lead to tachycardias. Okay. And the other system here is, which is very prominent, prominent and directly involved, is decreased noradrenaline clearance by noradrenaline technical inhibition, right? And which can happen because of genetic mutations, which can happen because of genetic modulations, which can happen because of medications like NET inhibitors, or SNRI medications. What is SNRI or NET inhibitors, guys? Tell me. What is NET inhibition? Yes. Yes, guys, what is SNRI and what is NET? These are the classes of drug. Tell me. NET is noradrenaline, or what else? Yes, guys, tell me. Antidepressants, absolutely, antidepressants. But full form, serotonin non-receptor inhibitors, serotonin non-receptor inhibitors. Okay, SNRI. Then NETI. Yes, NETI. Yes, guys, NETI. Yes, please tell me. Okay. Yes, guys. Yes, what is NET inhibitors? NET inhibitors. Okay, serotonin norepinephrine reuptake inhibitor, fine. That is antidepressant. But what is NET? Yes, guys. It is very simple. NE means noradrenaline I'm talking about, or norepinephrine. Norepinephrine, transport inhibitors. Okay. Norepinephrine. Norepinephrine. Okay, so norepinephrine transport inhibition. Okay, and similarly, these causes, what these causes, if there is tachycardia, or SNS traffic increment, or plasma increment, norepinephrine. Sorry, I was talking noradrenaline, right? I was and that is NA, not NE. Sorry, norepinephrine. I was mistaken here. That is NA, not NE. Okay, this is norepinephrine, not noradrenaline. Okay, that was NA, right? So yeah, so norepinephrine is directly involved in the pure tachycardias, right? So now let's see if the tachycardias and how the symptoms happens. If there is SNS traffic, or norepinephrine is having the low levels in the plasma, then what happens? What happens is it decreases the cerebral perfusion. Okay, it decreases the cerebral perfusion, and because of that you get the symptoms. Because of that you get the symptoms. So what are the symptoms of this, guys? Can you tell me? I mean, not high tachycardias, but if the cerebral perfusion decreases, what could be the symptoms of cerebral, perfusion decreasion? I mean, decrement in the, in the human beings. What could be the symptoms because of that? If your cerebral perfusion is decreased, what kind of symptoms will be happening? Yes, shock. CNS disturbances, convulsions, okay? CNS depression, okay? CNS depression is the mechanism again. Symptoms, shock, okay? Convulsions could be convulsions. We call them convulsions. Tachycardia does not cause convulsions at all. Dizziness, imbalance, what we call that? Majorly syncope. Have you heard of term syncope? Syncope, 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 right? And dizziness, blurred vision, those things usually happen, right? Syncope and these things happen in when the usually the cerebral perfusion decreases, and that all happen because of this mechanism, either autonomic neuropathy or hypovolemia or autoantibodies or primary increased in sympathetic activities or decreased norepinephrine clearance by the drugs, which are the usually antidepressant, okay, antidepressant, right? And those can directly impact the SNS traffic, and those can increase the norepinephrine levels in the plasma, and those actually goes to one sec, guys. Yes, so that's how the symptoms appear in tachycardia, right? Now, after mechanism of action, what's there? Common symptoms, what we're talking about is first of all, palpitations are very high, right? Or lightheadedness, fainting, syncope or fainting, chest pain, tightness, shortness of breath. These are the major symptoms of tachycardia, even, right? So, again, the symptoms are depending on type of arrhythmias you are experiencing. Like in general, these are the following symptoms as we usually have. Common side effects: nausea, vomiting, headache, right? Similarly, in the tachycardias, most of the symptoms are, even in the bradycardias, first of all, the chest pain, or the tightness of the chest, then palpitations, right? And then lightheadedness or shortness of breath. In tachycardias, majorly it is syncope or your fainting, we call it, right? So diagnosis, how do we do diagnosis? We know that now physical examination is first thing, because the same thing happens in either tachycardia or bradycardia, doesn't matter. You have to do the same thing, right? Diagnosis is same thing, right? Physical examinations, then ECG, then Holter monitoring, and then cardiac event monitor, then again implantable loop recorder, as we discussed yesterday, right? And then there are something called mobile cardiac telemetry, live arrhythmia monitoring. So these are similar to implantable loop recorder, but implantable is inside the body, and mobile cardiac telemetry is similar to, a little bit similar to ECG, but it is outside the body, and it is on the chest, and it takes care of your all the live events, and it sends all the signals to the doctor, right? That is mobile cardiac telemetry, okay? And you have seen the Holter yesterday, right? You have seen the Holter yesterday. Then we have seen the cardiac implantation recorder also. Now, other diagnosis definitely, I mean, same blood test and all, drug screen can be done, ABGs can be done, blood glucose can be done. Like as I told you, blood glucose can be done because blood glucose can lead to multiple things, right? Can lead to neuropathy, right? And then electrolytes, urea, and complete blood counts, and then sometimes pregnancy, okay? Pregnancy, because of hormonal disbalance can happen in pregnancy, that can also be a reason, right? So here there are two types of tachycardias, guys. Majorly we divide tachycardias into two types, right? One is narrow QRS, one is broad QRS, right? One is narrow QRS. You can see that narrow QRS only between, like, within two small boxes, okay? And broad QRS is, like 3 to 4 boxes it is involving, right? But you can see it is broad, right? Even the QR is broad, and then RST actually RST is broad here, right? So if you count from here to here, it goes, and it includes almost 3 to 4 small boxes. And this is very narrow, right? It is very narrow, very straight up narrow, kind of tachycardia. And in that narrow QRS, so tachycardias are not, checked by P2P, right? As we did in bradycardia yesterday. P2P in that, P2P distance is different, or P2Q different distance is different, right? That was in bradycardias. But in this, the whole QRS complex is being measured, right? So this is the ECG thing, what you should understand, how you should diagnose. So there are two types of arrhythmias. One is narrow QRS tachycardias, one is broad QRS tachycardias. Now, a very huge difference. If it is narrow QRS tachycardia, then it is supraventricular tachycardia. And if it is broad QRS, it is ventricular tachycardia. Now you'll tell me ventricular and supraventricular, what's the difference? Okay, so there is a difference because of the origination locality, like from where it is generated, from where it has come, right? And because of that only it happens, right? And because of that only it is tagged like ventricular and supraventricular, right? Ventricular and supraventricular. Now, can someone tell me where exactly from the ventricular comes, where exactly from the supraventricular comes? And next question for all of you is, which is more dangerous? Which is more dangerous? Supra from atria. Okay. Okay. Anyone else? Supraventricular tachycardia is tachycardia. I mean, ventricular and supraventricular tachycardia. What's the difference between locality and dangerous? Right? How danger? SVT is more dangerous. Okay. Anyone else? Yes, guys. Tell me fast, fast. We don't have whole day. Yes, people. Yes. Ventricular is more dangerous. Okay. Someone is telling ventricular is more dangerous. Supra is from atrium and more dangerous. Ventricular is more dangerous. Yes, guys. Yes. Fast. Okay. So, as it is ventricular, so ventricular is majorly originated from ventricle. Exactly, not from the ventricle. Okay, why we call them from? Why, these both are generated from atrium. Okay, both are generated from atrium, but still we call them ventricle because they are generated somewhere from nearby or related to AV node. Okay, understand the lower side of atrium, the upper edge of ventricle, the septum between atrium and ventricle, the septum between atrium and ventricle. That is the major, I mean, that is the locality, or that is the origination point for ventricular tachycardias. Understand? That is the originated place for ventricular tachycardias. And for narrow tachycardia, supraventricular is 100% ventricle and upper part of the ventricle, usually upper part of ventricles, right? Where exactly the blood is received and where exactly or near to SA node. You understand? Near to SA node, upper part of atrium. Ventricle is lower part of atrium, or ventricle, or I mean the septum between atrium and ventricle, right? So that is ventricular arrhythmias, and narrow QRS are supraventricular arrhythmias. So those are in the upper part of atrium, right? Upper part of the upper chamber, right? Those are supraventricular tachycardia. You can see the ECGs now. Look at the ECGs. So it is very obvious. See, these are very narrow QRS complex, right? This is very new narrow QRS complex. And here it is wide QRS complex. If you see, this is wide QRS complex, right? So this is supraventricular, this is ventricular tachycardia. And if you calculate, this is again, more than 100 and this is more than 150, right? If you calculate. So this is always remember that if the QRS complex is wide and heart rate is more than 100, that could be broad QRS ventricular tachycardias, right? And if the QRS is intact or narrow and the heart rate is more than 100, that could be supraventricular tachycardia. One more thing is there that makes, differentiate. I mean, that actually differentiate in broad QRS. You know, that is distance. Okay, distance again is different in different arrhythmias, right? So we'll talk about that, but majorly today, basically, these arrhythmias, tachycardias are categorized into narrow and broad QRS. Okay. Then here are the tachycardias, right? Types of tachycardias. So narrow complex tachycardias, wide complex tachycardias. Remember, that is very important what we're going to do. Okay. So in narrow complex tachycardias, regularity and irregularity. Guys, that is important. In narrow complex, regularity and irregularity. Irregularity means, regular means the constant rhythm will be at the same pace. But in irregular narrow complex tachycardias, the rhythm distance or rhythm pace will be different, or it will be varying, right? The pace of rhythm will be varying. Pace of beat will be varying. Distance will be varying, right? That will be irregular narrow complex, and regular narrow complex means consistent, the same pace. But irregular means, irregular means like there will be, the rhythm or the distance will be varying, right? So what are the types? In regular, there is sinus tachycardia, atrial flutter. Atrial flutter is in regular. Atrial fibrillation is in irregular, right? Atrial fibrillation is in irregular, right? Then AV nodal reentrant tachycardia is in regular. Then, reentrant tachycardia, both nodal or without nodal, both are into the, like, reentrant tachycardias are always regular, right? And junctional tachycardias, atrial tachycardias, I mean, almost, all are into the regular. But AF, atrial fibrillation, is into the irregular one. Okay. And atrial flutter with variable, atrial flutter also, atrial fibrillation, atrial flutter with variable conductions, right? I mean, mostly, majorly, I mean, AF, that is atrial flutter. Flutter is usually regular, but in some cases where there are some variable conductions that could be there. And multifocal atrial tachycardia also is irregular. Usually, the atrial tachycardia is regular, but multifocal means generated from multiple places at a same time, at the same time. Multifocal means the generation of arrhythmia is happening. Sir, can you send PPTs of previous and present class in WhatsApp group? Dear, I'm sending the recordings, no? You will have all the recordings with you. Okay, don't worry. Yeah. So this will be, I mean, this will be classified, narrow complex will be classified based on regular and irregular, right? And then it comes to the wide complex tachycardias. Wide complex tachycardias are, usually ventricular tachycardias, not supraventricular, right? So ventricular tachycardias could be monomorphic or polymorphic. Monomorphic means which looks like one only, like, I mean, everything looks like one type, right? I mean, one type, one pattern, either regular pattern or irregular pattern, the pattern will be similar. Okay, pattern of QRS complex will be similar, either the distance is different or not, it doesn't matter, but it will be looking similar. All the paces will be looking similar, all the QRS complex will be looking similar, right? That is in the monomorphic. Either those are regularly presenting or irregularly presenting, that doesn't matter, but those will be monomorphic, like similar looking. Some wide complex tachycardia is polymorphic. Polymorphic means, like, the look wise, every ECG wave, every rhythm will be different. Every rhythm will be different in ECG. We will see when we are discussing these things, we will be seeing one by one. Okay. So in polymorphic, that is, what we are hearing from you every time, like, you have seen this French name, right? Torsade pointus. So this is the polymorphic wide complex tachycardia. Okay, and then ventricular fibrillation again. And if you look at the monomorphic, then in the monomorphic, that is, ventricular tachycardia is monomorphic, regular SVT, supraventricular tachycardias with wide QRS. Some supraventricular tachycardias are there with wide QRS, those come in this, right? Or regular SVTs with aberrancy are in that. Pacemaker related arrhythmias are also regular monomorphic, and irregular, there are some regular SVTs. So I mean, there is not nothing new to understand, but all the tachycardias with monomorphic or irregular regular things, SVTs also can come into this. Okay. And then that is all about classification. So I hope you understand here. Till now, any question, guys? Till now, any questions? Yes, people. Tell me if any questions. Yes, 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 people ask. Clear. Okay, very nice. Aberrancy. Okay, regular SVT with aberrancy means absence of rhythm. SVTs, like we see in the cardiac block. Cardiac blocks are not, SVTs or VTs, right? Cardiac blocks are different, right? But as we see the absence, so there will be regular SVTs, right? Regular pattern. The pattern will be monomorphic, regular, monomorphic pattern with regular intervals, but in between there will be absent of one arrhythmia or two arrhythmias like that, and not at the consistent intervals, but that can be at any point of time. There will be some absence of arrhythmias. Aberrancy is like related to absence of arrhythmia, absence of, sorry, absence of beat, right? And that can happen because of, multiple reasons. Similarly, like if there are any other cardiac problems, if there are, any, different issues, so that can lead to, the aberrancy in the SVTs, right? So regular arrhythmias also, like regular supraventricular tachycardias with aberrancy can be, you know, defined as defined into the monomorphic regular wide complex tachycardias. Right? Any question, guys? Any other questions? Ectopic beats and absence are different. Ectopic beat usually, it can happen normally also, ectopic beats, right? And that can happen in arrhythmias also. Ectopic beat can happen in, normal arrhythmias. Without arrhythmias also, people can face, ectopic beats, and people can have the ectopic beats, usually sometimes in the arrhythmias also. We cannot say these are same things, but yeah, missing the beat is ectopic beat. Yes. The reason for irregular arrhythmia, reason for irregular arrhythmia, simple. There is no specific reason in that. Simple reason for irregular arrhythmia or irregular pattern is that disturbance, voltage variation, voltage which are generated from SA node or AV node are varying, right? Voltage variation is irregular. So see, you have to understand, you can really understand the whole thing here in this diagram. First is wide complex. Suppose wide complex means QRS complex is wide. Monomorphic pattern is similar, right? And it is irregular. Regular means like, okay, because of the arrhythmia, because the we are defining arrhythmia, the fast rate is there, but fast rate is happening because of large QRS complex, wide QRS complex. Okay, but the pattern is monomorphic, pattern is similar. Now it comes to regular, irregular. Regularity and irregularity happens completely, completely depending on the arrhythmia. Completely depending on the, impulse generation, or, the how the charges are coming out of SA node or AV node, right? If the whole thing is disturbed, then maybe, the flow of charges or generation of charges from SA node and reaching to, AV node, and how they are circulating could be irregular. Those are not regular, right? Those are not proper. So those are varying because the entire system is disturbed. right? Entire system is disturbed. Now high heart rate can cause that, okay, or slow heart rate can cause it because of, autonomic nervous system, definitely. So the generation of impulses can be varying in every arrhythmia. It is not regular, right? And because of that, the beat, I mean, the heart contraction and relaxation will be different, and that same thing will be reflecting in the ECGs. Understand? So that is all on the impulse generation or the charges generation from SA node. Okay. Any other questions at this point of time, guys? Yes. You understand or not? Yes, people. Tell me. Did you get it? Okay. Let's go further. Fine. Types of tachycardias we have seen, like multifocal tachycardias. So multifocal atrial tachycardia is a rare condition in which atria sends too many signals to the ventricle, not only one signal, right? As I told you, multiple generation, multiple generic point will be there, and it is generated from multiple points or multiple types, right? So multifocal arrhythmia is where arrhythmia has multiple point and sends too many signals to the ventricle at the same time. It usually seen in the people with cardiopulmonary conditions. Okay, in the people cardiopulmonary conditions, there could be, the re-entry of arrhythmia can happen at many places because of that multifocal atrial arrhythmias. Then paroxysmal atrial arrhythmia. Paroxysmal atrial arrhythmia causes the atria to go in and out of atrial tachycardia. Okay, so like it is completely happening in your atrium, but because of this, like whole functionality is disturbed, right? I mean, whole functionality is disturbed, and it is usually not from, I mean, the SA node is generating, but actual points of generation are, depending. Like, have you seen that how the hackers do, the mobile will be, your mobile location will be in Mumbai, but they will be operating from Chennai, right? Like that. So the impulse generation point will be somewhere else, but everything is operated by SA node, but the things will be from different, right? So kind of short circuit, right? When a short circuit along with unusual pathways, right? Short circuit along with unusual pathways of electronic signals. Simple, it's very simple. Yes, when I'm talking about these things, I will be telling you, I'll be showing you the ECGs of everyone. Of, I mean, all these things. Okay, don't worry. Then sinus tachycardia occurs when the sinus node, I mean, your SA node, the heart's natural pacemaker, sends out the signals that are causing heart to beat faster than normal. But those are just temporary acceleration. Sinus tachycardia is normal one, right? Where this is just temporary acceleration because of your, either caffeine intake, high caffeine intake when you take high caffeine, or because of exams, or maybe you take a lot of Red Bulls, right, or energy drinks, or maybe intense exercises or some normal triggers, right? So that can trigger your SA node to generate more impulses, or to it actually, I mean, when I'm talking SA node means it is sympathetic nervous system, right? I mean, your nervous system is super activated by caffeine, by intense exercise, or by other triggers, and that can definitely call your SA node to generate more impulses and to make the heart work faster, right? So that is sinus tachycardia. Ventricular tachycardia is the tachyarrhythmias that begins in the ventricles, usually at the upper edge of the ventricle, and definitely, there could be at least three irregular beats in a row that can be life-threatening, right? I mean, if there are three irregular beats, heartbeats in a row, that can be life-threatening. That's why, like, your atrial fibrillation is one of the most dangerous tachycardia. Atrial fibrillation, right? Atrial fibrillation is one of the most threatening tachycardia. Atrial fibrillation, so it is most common type of heart arrhythmia as well, in which the two upper chambers of your heart are affected. That is atrial. Atrial means atrium, right? This disrupt the blood flow to the ventricles and the lower chambers, and then throw out the rest of your body, right? So it disturbs the atrium to work and because of atrium, the blood flow to the ventricle is not proper. And if the blood flow is not proper, definitely the blood pooling and all happens, right? And then because of that, your heart is completely affected and it is not circulating the proper blood to the body, right? Atrial flutter is type of abnormal heart rhythm. It occurs when the upper chamber of heart beats too fast, causing the bottom chambers also beating faster than normal. Right? Atrial flutter means, okay, like that from one to another. Right? So it happens like if the upper chamber is beating fast, it is making the lower chamber also beating fast. In atrial fibrillation, it doesn't happen. Okay, in atrial fibrillation, it doesn't happen. Okay, atrial fibrillation that disrupt the things and your upper chambers are faster than the lower chambers. Okay. So types of tachycardias, I think we have already discussed these things, but this is something else. Like tachycardias, supraventricular and ventriculars. We are dividing here into the ventriculars, not QRS based, but location based. Okay, so supraventricular tachycardias and ventricular tachycardias. So supraventricular tachycardias only requires atrial tissue. Okay, so they are calling atrial tachycardias, like atrial fibrillation, atrial flutter, atrial tachycardias, right? And if they need some junctional tachycardias, if there is AV node also required, like ventricle muscle is also required in this, then that is called AV junctional tachycardias, right? And those are nodal reentrant axillary pathways, and those are usually that type of arrhythmias where AV node is also included, means the lower chamber is also I mean the ventricles muscle also are involved in that, right? And then there are totally ventricular tachycardias which are at the upper chamber of ventricles, right? So, potential underlying causes of tachycardias, mostly POTS. POTS is postural orthostatic tachycardia syndrome that describes a group of neurological conditions in which the body sends abnormal signals to the brain and heart when you change positions, such as sitting or standing. Many people feels that their heartbeat is raising when they are standing. Many people feels their heart rate is, you know, good, correct, when they are lying down, or when they are walking, that again goes up, right? So that most of the things are related to your orthostatic tachycardia syndrome, postural orthostatic tachycardia syndrome, POTS, right? Such sitting standing positions that can call that, right? So, and then there is something called Wolf Parkinson White syndrome, WPW syndrome. Okay, WPW syndrome, WPW syndrome is the immature beats usually. Okay, these are immature beats, right? So Wolf Parkinson White syndrome is a congenital heart condition, usually congenital heart conditions in which the heart has an extra electrical pathways. It can be potentially serious medical conditions. Medications may help ease symptoms, and cardiac ablation may be effective in destroying the abnormal pathways. So what does it mean? What is Wolf Parkinson White syndrome? That appears, that Wolf Parkinson White syndrome that appears usually in young age. It is definitely the congenital heart disease, but that symptoms appears when the person is adult or in adulthood, right? That time a lot of hormonal changes, a lot of body changes happens, so that time that comes to existence. Okay, and what exactly it is? Suppose you have your SA node, which is the pacemaker of your heart, right? But other than that, there are also some electrical linkage. Electrical linkage means not exactly SA node, but there are also some spots in atria, okay, or some external spots. Okay, some external spots means from where the body can, or from where that sinus your sympathetic nervous system can operate, right? Some what is SA node? SA node is not some specific where there is no generator, there is no power, there is no your lithium, right, in the body, but that is the cluster of neurons, and because of the electrolytes and the reactions, chemical reactions in the SA node, that generates the impulses, right? Similarly, because of congenital heart disease, there could be some other spots in the atria, or there could be some other spots at pulmonary artery. Okay, there could be some other spots, right? So those spots are are usually in this usually in the dormant stage when the kid is born, but when they go to the adulthood, that time they usually come to the existence, or they come to the they become active, and they causes this kind of immature beats. They don't cause, or they don't create the normal beats, they creates the abnormal beats, and those abnormal beats can be appearing in your heart rates and ECGs, and that is called Wolf Parkinson White syndrome. This is not so dangerous, but yes, it could be fatal sometimes if it is not treated well, or if it is not treated on time. Okay. Right. So, what are the potential underlying causes of tachycardias? First is elderly. Anemia. Anemia is one of the major cause of tachycardia, guys. Anemia is one of the major cause. Then it could be diabetes, family history, heavy alcohol use. That could be for bradycardia also. And then high blood pressure, sleep apnea, smoking, stress, thyroid disorders. These are the underlying causes of tachyarrhythmias. Right. And potential emergency is definitely when see someone that their heart rate is going more than 100 beats per minute, and that is raising more and more in time, right? And they even feel the chest pain, trouble in breathing, shortness of breath, or maybe they are fainting or nearly fainting. Okay, they are in the syncope stage, right? So that could be your the signal to go to the emergency, right? And tachyarrhythmia should be considered a serious medical concern for anyone, but especially who already has any heart disease or previous heart attack, any hypertension or hyperthyroidism or severe anemia. Okay, but I mean, less than 9 or less than 8 or less than 10 in the man. Hemoglobin, that could be very concerning for the people, and that in that case, definitely you should rush to the emergency situations, right? So these are some indications how you should recognize the potential emergency in tachycardias. Okay. So, management of tachycardias. I thought I will teach you this, but why I'm not teaching you this is common one. Okay, and this will be a different things. But okay, if you want to understand, I can make it understand simple. But this is a common one. Okay, this doesn't work for all. This is again usually goes with standing of your QRS, right? How the QRS is based on that you can commonly check. Otherwise, for AF and all, those are some different mechanisms are there, different treatment patterns are there, but still let's understand this. Okay, these are the European resuscitation guidelines. Okay, ERC guidelines, European Resuscitation Council guidelines 2021, right? So how it is like, first of all, if the patient is having tachycardia, definitely assess with ABCDE approach. Okay, ABCDE approach, right? Give oxygen if the SpO2 comes down to 94 or less. Okay, and then definitely monitor ECG, blood pressure, and record 12 lead ECG, right? Record 12 lead ECG in that cases, and identify and treat the reversible causes like electrolyte abnormalities, hypovolemia, or maybe hypoglycemia or hyperglycemia. So immediately take care of that, right? First ABCD approach, and then life-threatening features. Check for life-threatening features. If there are any life-threatening features like shock, or if there is any syncope, if there is any myocardial ischemia, or maybe some severe heart failure, these could be your life-threatening features in any tachycardia. So finding out these can save the patient. Otherwise, that could be lethal. Okay. So first is shock, then syncope, myocardial infarction, or ischemia, then severe heart failure. If these things or one of these things is appear, then immediately synchronize shock up to three attempts. What is synchronized shock? Like your defibrillation. Okay, defibrillation with resuscitation is synchronizing shock. Up to three attempts. Okay, then sedate or anesthesia if cautiously. Otherwise, if unsuccessful, then if your resuscitation and defib, okay, if your resuscitation and defib, like which is synchronization, if that doesn't happen, right? If doesn't happen, defib and your resuscitation doesn't happen, then in case you should go for immediately amiodarone 300 mg IV over 10 to 20 minutes, or procanamide 10 to 15 mg per kg over 20 minutes, right? And immediately after that, repeat synchronized shock. Okay, defib, reduce defib in that cases, right? So in that case, that can be a lifesaver to the patient, right? If you have life-threatening features, then go for the synchronizing shock for 3 attempts. First attempt, like sedate. If it is not, if the patient is, conscious, or you can give anesthesia. And then if this, synchronized shock, like the defib unsuccessful, then amiodarone or procainamide, and then repeat that, right? And if there is no life-threatening features like shock, syncope, myocardial infarction, or heart failure, in that case, let's check if the QRS complex is wider or narrow, right? Is the QRS complex narrow? Narrow means less than 0.12 second. Okay, less than 0.12 second, right? No, synchronized shock is defib, use of defibrillation. Okay, defibrillator. Okay, so that is there. So I'll talk about that in when we are talking about AF, atrial fibrillation. That I will talk. I will explain that in the slide as well, right? So that is using of defibrillation, right? Okay, so QRS, when the QRS complex is narrow, if your QRS complex is narrow, less than 0.12 second count, that is, if it is 0.12 second, in that case, if it is yes, it is narrow QRS, then check if the rhythm is regular. Okay, if it is broad QRS also, check if the rhythm is regular, right? So if the rhythm is regular in any QRS narrow or QRS, wide, doesn't matter, go for vagal maneuvers. Okay, vagal maneuvers, right? So what is vagal maneuvers, guys? Can someone tell me what is vagal maneuvers? Anyone can tell me what is vagal maneuvers? Anyone have heard of vagal maneuvers? Yes? Anyone of you heard of vagal maneuvers? Bending of ears. Yes, ma'am. One type, like one of the activity. Yes, absolutely. Bending of ears. Check. This is the assignment for all of you. Okay. Check what are vagal maneuvers and tachycardias. So there are multiple activities. Breathing in paper bag. Okay. Yes. Yes. Anything else? Usually your legs in the air. Okay. Or your multiple activities are there. You check out. I'll not tell now. Okay. You check out what is vagal maneuvers. Okay. If the tachycardia is happening without life-threatening features and QRS is, doesn't matter QRS is narrow or this, but if it is regular, then we go for vagal maneuvers. And if the vagal maneuvers doesn't work, then we go for, adenosine, right? We go for adenosine 6 mg rapid IV bolus, right? And again, if unsuccessful, go for 12 mg. If again unsuccessful, go for 18 mg. Okay, and that's how you go for it. 3 doses, right? Okay, like not 6 mg after 6 mg and 6 mg. No, if 6 mg is not working, then give 12 mg. If 12 mg is not working, then give 18 mg. Okay, and then monitor ECG regularly. Again, if the adenosine is also ineffective, then go for procainamide or amiodarone. In case of broad QRS, in case of narrow QRS, go for verapamil, diltiazem, or beta blockers. Okay, go for narrow QRS, verapamil, diltiazem, or beta blockers. In broad QRS, procainamide or amiodarone. Okay, that could be happening. And if it is also ineffective, then we can go for synchronized shock up to 3 attempts. So that is the emergency or non-emergency impact, emergency and non-emergency management of tachycardias, right? And if again, like if broad QRS is irregular, then treat as narrow complex. And if AF with bundle branch block, give 2 gram of magnesium over 10 minutes. If torsadо de pointus, right? So, and then in case of atrial fibrillation, irregular narrow QRS, then control rate with beta blockers or diltiazem, right? Consider digoxin also sometimes or amiodarone if evidence of heart failure. If there is any heart failure, then go for digoxin or amiodarone. Right? Anticoagulation can be started in case of AF within 24, I mean within 20, sorry, within 48 hours. Like if the duration is more than 48 hours, if it is continuous or irregular also, like on and off episodes, we start anticoagulation because it can cause MI, it can cause stroke, it can cause peripheral vascular disease or atrial vascular disease. It can cause multiple disease, it can cause related to blood problems, right? So in that cases we should go for anticoagulation. Understand guys this or not? Tell me, is it okay? Any questions guys? Clear? Okay, great, thank you. Thank you guys, thank you. Let's go to the next slide then. I think after that, your natural ways to help cope with tachyarrhythmias, definitely, acupuncture or the use of vitamins and supplements such as magnesium to boost your heart health. Okay, you can start in the uh, like after 30, after 40 usually, or in the elderly people, definitely magnesium can help to boost your heart health, or vitamin supplements can help, right? Or that can be naturally, like you can start eating healthy or start eating green, right? Other lifestyle strategies can help, like meditation to lower your stress levels, safe exercises under the direction of a doctor or cardiac rehabilitation specialist, right? So and a lot of other things can be involved, which can, like alcohol, completely, alcohol is as the reason. So you can stop alcohol, you can stop caffeine or cut down the caffeine, because caffeine is dangerous. I always tell, being into the cardiology, I can say proudly caffeine is dangerous to the heart. People drink four coffees, three coffees a day, even two coffees a day is dangerous. Two coffees a day are not good. Okay, so caffeine should be in the restriction, very, very restricted things. You must have seen the studies also how caffeine is affecting the heart. Like salt is very dangerous to the heart, right? Similarly, caffeine is dangerous to the heart. Okay, and over excess, people drink cold coffee, people drink hot coffees, and then it can really causes the problem to your heart. And then definitely overeating is one of the reason, right? Smoking, stressful situations, not getting enough sleep, right? These could be the natural ways to help help yourself from tachycardias. Okay, what about red tea? I have no idea, but tea is good. Tea is good, but under, again, in the restricted thing. Okay. Yes. Okay, guys. So that's all. Anything else? Yes, guys. Any questions now? Any questions, guys? So I hope you understood today's class. Did you get it? Questions, guys? Thank you, ma'am. Thank you. Okay, then if okay, then we'll close it out, and tomorrow I'll take the class in the morning. My main query is how to identify all these arrhythmias in a ECG. Array, ECG only I'm teaching majorly. That wide QRS, short QRS, supraventricular, ventricular. I'm showing you the ECGs. And one by one in each, when we are teaching one by one, all we are. Yesterday in Brady arrhythmias, I showed all the ECGs, right? So it is not, see, if you are just learning the ECGs only, if I just come up with the ECGs only, how will you understand the things? Like you don't know the background at all. So I have to come up with the background also, na? How can you just go without background to just understand the ECG? See, ECG means if I tell, see, in this ECG will be practiced when there is individual arrhythmias, right? This is common, right? This is common. So you will see the ECG and you are seeing the ECG. If you just try to define, check by yourself now. See, if you can check, like go to Google or check in the hospital. If you're going to the hospital, just find out, try to check the ECGs of cardiac patients and you will come to know if it is tachycardia, bradycardia, or if there is any problem, right? So that you will understand, na? And this is a basic class. Today's class is basic. Yesterday's class, things are going. There is a way of teaching, way of understanding, you know, always. If I just tell you ECGs, you will not know what are the reasons why it is happening, what is the mechanism of action. If I'm not teaching you mechanism of action, not teaching you what are the reasons, not teaching you how it happens, not teaching you the types of the arrhythmias, how will you understand? Tell me. If I don't tell you, like if it is narrow or broad are different, how will you identify in ECG? Tell me, Rang. If you don't know the basic things, how can you understand the complex part? Yes, guys, fill the attendance form, please. Okay, any other questions? Any other questions? Yes, guys, questions? If no questions, we can wind up. We'll see you tomorrow. I'll tell you time. Mostly, I'll take in the afternoon only. Okay, be ready. Somewhere around 2 to 3 or 3 to 4, I'll take the class. Okay, be ready, but I'll take tomorrow. Okay, bye bye, guys. Take care. See you. Good night. Have a good food, guys.